Thank you, Pedro. You know, when you're last, you better be fast, right? So, a couple of interesting things. I know of all the complex cases that Dr. Sharma and his crew have done, there were no lemurs there. So I thought I'd focus on that. I might focus on that. Okay, obviously the lemur is considered to be God's gift to bypass surgery. 91% patency at 10 years. This is the other 9%. 51-year-old with a prior cabbage has a new problem, expanding type A dissection referred with an anterior wall MI. So from the ER, rather than come right to the lab, goes to the CT scanner, and this is what you see. Whoops. Quick one, you got that? Huge ascending aortic aneurysm. Most of the native vessels are occluded. And you probably didn't pick up on something else, so I put down the radiologist's interpretation, that there is an intimal defect in the root in the ascending aorta without arch or descending aortic involvement. And there's a new long segment of severe stenosis in the left internal mammary artery to the left anterior descending artery at its interposition point. A couple of other things that you can see there, but he's pretty much dependent on this lima. So here's the first picture. To my esteemed colleagues, what do you think's going on there? Clearly there's a lesion in the mid portion, which looks like it's adhered to the underside of the sternum. How about distal to that?
Show us another picture.
You can see that the lima's fitting the right coronary, so we're kind of in a tenuous state here.
Yeah,
So how about an
it
IVUS?
looks like a dissection.
Yeah, it looks like a dissection.
Good point, Pedro. How about the IVUS?
Spontaneous or, extended from the type A flap.
But you don't see it.
Good pickup, right? Even limas can dissect spontaneously, particularly in somebody who has an aortopathy like this. They can easily go down. So first thing, of course, was to get a wire down, and that's no small feat when the dissection's that long and that extensive. And then we saw a lot of thrombus in there too, so we did thrombectomy first. And then you better get all the longest stents you have, because it's going to be a trail of metal. And this is eventually 4 stents later, and this looks fine. So this patient was allowed to recover, did fairly well. 3 months later, had a reduced sternotomy because we still got the main problem of a type A, of an ascending aortic partly dissection and aneurysm. Their initial ejection fraction pre-op was 20%, but with a prolonged recovery and support and guideline-directed medical therapy, was discharged with an EF of 35%. You can see that the surgeon decided to put in a 25 millimeter Magna Ease, replace the ascending aorta, and did a Cabral procedure to try to minimize any further involvement of the grafts going into the native circulation. Next quick one, 66-year-old prior cabbage now presents with a non-STEMI. Initial diagnostic catheterization suggested there's a lima anastomotic lesion at the outside hospital, and so it was brought to us for PCI. The patient has an included native LED and a patent left dominant circumflex. Uh-oh. What's going on?
Dissection.
So the first one was a endogenous dissection, naturally occurring. This is clearly more iatrogenic in nature.
See, you see the dye on the subclavian, yeah.
Very good, Pedro. That's why I got you up here right next to me. Okay, I needed you. Where were you when I needed you? So we've got a long dissection down a lima, which is totally dependent, the LED is totally dependent on this, and we've got a dissection of the subclavian as well. So you start out blind, of course. You can't really see where you're going. The wire, Murphy's Law says that the wire is going to follow the false lumen. So somehow you've got to try to work it out and get downstream. Get a few stents in there. And I'm not able to cross the primary problem, which is the anastomotic lesion. I can't see anything. Nothing goes through there. But at least I can try to get something going proximally and mid with a few stents, and then finally switch over to a hydrophilic wire, getting through the anastomotic lesion, and then go ahead and finish that up with a stent down there.
Wonderful.
What would you like to do next? Anything? Pedro, you're my vascular consult.
You want to do imaging?
Yeah, there's, well, we imaged that, it looked fine. The subclavian looked like on a few indirect shots, was like it kept flapping in the breeze here. So Here's the non-selective shot.
Man,
Yeah, you got troubles there. So,
a whole proximal dissection,
exactly,
almost to the ostium, yeah.
exactly. So, this has to be stented. This is a 10 by 60 vascular self-expanding stent. Didn't compromise the vertebra, which is nice. Did not cross over the lima, which is also nice. But you can see how the dissection fills around the stent. Fortunately, we spared the ostium there with the stenting to keep it patent, since the patient did well long-term. Last one. Case 3, 87-year-old female has a prior biologic AVR and coronary bypass grafting, has chest pain and dizziness. Local hospital does a CT scan, and according to their reading has a large 6-centimeter aneurysm of the left internal mammary graft. She was referred to our institution for angiography and consideration of surgical management. So going into this, I have no idea really what they're talking about other than I'm supposed to see some lima aneurysm. Anybody ever seen a lima aneurysm before? Maybe at the ostium, at the anastomotic site. That's the only thing. I will tell you on a chest x-ray, I don't have this here, there seems to be this fullness that says, oh, there's got to be an aneurysm there. So I said, I went with it. Let's just take a picture of the lima and see what it shows. I don't see anything. But the lima is tracking over some spherical area there. See how it kind of goes up and over that? Putting a little tension on the lima, might be producing some ischemia. Well, nobody had ever bothered to look at the rest of her vasculature. She had an SVG to the marginal, and so I did a picture of that. Let's see if the marginal's open.
Oh,
What's going on there?
see it.
Here, just sit over.
Yeah, exactly, Art. There is something, obviously the marginal graft is occluded, but there's something sort of injecting into this large circular object that the lima was going over and was misinterpreted as a lima aneurysm. So let's do an aortogram.
Yeah.
That's big. So now the surgeon comes to me, I called him down, I said, listen, we didn't find what we were expecting to find, we've got this. He goes, I said, maybe you should take them to the operating room. He goes, no way. This one's all yours. So what can you do? Of course, first let's take a better picture. This is an AL1 guiding catheter, put a Terumo glide wire inside of this. Got an idea to see what the size of it is, because it looks small, but there's a balloon kind of fills out, it's 7 millimeters. Gives me an idea of what size device I might need to close this off. Of course, the devices are not really made for delivery to this kind of an area. So you've got to put an extra stiff wire like a Lundquist in the cavity. Neither can I deliver an ASD device through an AL1 guide catheter, so I have to exchange that for a torque fuse sheath. And based on the diameter of the balloon, just went with some fudge factor, increased the size, put a 12 millimeter ASD occluder in there, and get this, detach it. You can see how it releases from the tension because this is under a lot of strain trying to get into this particular area. And this is the final picture, and that's without reversing the anticoagulation. So there's virtually no flow going inside of this. The patient did have a follow-up CT scan. It didn't show a lima anastomotic, it didn't show a lima aneurysm, but it did show that the aneurysm coming off the aorta is completely thrombosed off.
Wow.
It did well. So, conclusions, limas are the best bypass conduit, but they can be fragile. Anybody who knows who've abused them once in a while, when they start dissecting, they don't stop. They just keep going and going and going. They're sort of like the ever-ready bunny, and they just don't stop. But be careful about that when engaging. Be cognizant of the fact that they can dissect spontaneously and have fun. Thank you very much.
Beautiful.
Unbelievable.